Good morning, everybody. I know we probably still have some people coming in, but let's go ahead and get started. Hey, everybody. Thank you all for coming to day 2 of the 4th Annual Women in Data Science Charlotte Conference. My name is Katie Thomas, and I'm the marketing manager for the School of Data Science here at UNC Charlotte. I'd like to thank our sponsors for this year's event. Lowe's Incorporated has been our title sponsor for WID Charlotte since its inception 4 years ago. Atrium Health, Wells Fargo, Genesis 10, and the Fisher Family Foundation are also sponsors this year, and we're very lucky to have them. Lastly, we could not host WID Charlotte without the WIDS Worldwide Initiative. Before we begin this morning's panel discussion, we would like to share a quick video from our title sponsor, Lowe's.
We have one of the most talented .com and tech teams in retail right now. We've invested the capital to make sure we do it correctly, and we're starting to see the work pay off.
Lowe's, the terrific home improvement chain, just reported magnificent quarter with a huge earnings beat.
One company that's also doing it well is Lowe's. They're big investments that they made in the e-commerce platform, so really starting to see those investments pay off.
You and I have talked a lot about the power of omnichannel, in-store, online, buy online, pick up in store, curbside, you name it.
You've got an energized group and a loyal group. You have decided to work closely with Google Cloud, which has become very aggressive. You had amazing triple digit, and yet at the same time, you have said on the call that it's not even finished yet.
And with that, I'm honored to welcome Shika Kashyap, CEO of HealthInsights.ai, CTO and founding partner of Centelli Solutions, and founding member of the School of Data Science, to introduce this morning's panelists. Shika, I will pass it over to you.
Thanks, Katie. Happy Friday, everyone. And hopefully you were able to join us yesterday and will continue to participate in this conference. My name is Shika Kashyap Bhatnagar. I'm the CEO of Health Insights. We provide prepackaged analytics products for healthcare industry and associated services. I'm very passionate about data for social good, and I've been part of a couple of hackathons, especially on human trafficking and economic mobility. I also co-chair Women Charlotte Chapter, a professional organization of senior women IT leaders. Topic that we have chosen today is about the resiliency and elasticity in our healthcare system post-COVID, and it's a very relevant topic in today's environment. The pandemic took us all by surprise, but our healthcare system and frontline workers were the one who took the brunt of the impact. The system was stretched, tested at multiple levels, information was collected, distributed, physical capacity constraints, and the urgency to develop the vaccine to combat. There were mistakes made and lessons learned. So in today's panel, we will discuss not only how data was collected and used, but more importantly, how the yin and yang of data and digital will help us improve the resiliency and elasticity of our healthcare system. So let us start with the introduction of our panelists, the trifecta of healthcare experts. We have one from a provider, one from the payer, and one from the life science company for a discussion on this topic. So we'll start with Megan Shehu. If you can introduce yourself.
Hello, everyone. My name is Megan Shehu. I am a pharmaceutical executive, have spent 20 years actually at Pfizer Inc. in different roles in analytics, commercial, and the last decade has been focusing on digital and data. Now I'm heading for Galderma, the digital and data transformation for their prescription business. And I'm really happy to be here. And thank you, Shika, for inviting me here because I'm passionate about women and their growth in the business. So I would be happy actually to be contacted after this meeting in case you have any questions. So very happy to be here.
Thank you, Sue. Megan. Next, we have Susan Odom. Susan, if you can turn on your camera and introduce yourself.
Morning, everybody. I'm so happy to be here this morning. I am the Director of Statistics and Methods for the Musculoskeletal Institute at Atrium Health. I'm Senior Research Scientist for OrthoCarolina, and both of those are payers. Atrium Health is a large healthcare system. OrthoCarolina is a private practice, physician-owned practice. And I'm adjunct faculty in the School of Data Science and Public Health Sciences at UNCC. So I'm representing the provider side, and my passion is using data to help doctors treat the right patient at the right time with the right care, and giving patients a quality of life and better outcomes after care.
Thank you, Susan. And then we have Tina Foster.
Hi, thank you, Shika. It's such an exciting opportunity to be here. So thank you for inviting me and to all you who are attending and to my panelist members. What a great opportunity to network. I'm a clinician by trade, but also I'm a vice president now of data insights and innovation at Anthem. And so my role works together with Anthem being a large payer with touching over 80 million member lives. And we have a large diversification of business that really crosses that whole person care journey. And so my job is to be able to mash up all of that data from the entire care journey and to be able to create new insights that are really going to help innovate the way we treat members, treat ourselves, our neighbors, our families in a more whole person care perspective. So thank you for having me. My superpower, if you will, or my passion is about being a compassionate agitator. And so that's a really big part of using data to drive curiosity, to really keep pushing people and using the data and the insights to be able to agitate the status quo so that we can get to innovation.
Thank you. Thank you, ladies. So let's quickly jump on to this topic. So we all know as the COVID-19 restrictions came into effect, patients faced difficult choices about whether and how to continue their treatments. Sorry. And the healthcare system, they were working tirelessly to deliver quality of healthcare while protecting the well-being of non-COVID patients and the healthcare workforce. Clinical trials, we know, were disrupted by COVID-19. So my first question is, how did COVID-19 impact the customer behavior, and how did your organization address the patient engagement? Mm-hmm. So Megan, you want to start first?
Okay. So for the people in the audience, when you think about a pharmaceutical business, the way pharmaceuticals behave is that they educate physicians around new drugs, new treatment paradigms, and they educate patients. And normally the model is that you send a few sales representatives and then you talk to the doctors. And for patients, the model is that they go and see their doctor face to face. So that's the world we have been existing pre-COVID. But as we all know, that was not possible for many months of our lives. So what happened was that telemedicine emerged as a way for us as patients to really go and see a doctor. Instead of going face to face, a video call became the norm. And for pharmaceuticals, our sales representatives started emailing videos of themselves to doctors so that they could tell their story about their brands or the disease area and so on. So what was observed was this immediate practical way of engaging that use technology in any form possible to really continue to see the doctors, continue to educate the physicians, and continue as patients for us to really get care. So talking about the resilience of healthcare, I think technology enabled all of us really not lose touch with each other, but not lose touch with ability to get care during this COVID times. And obviously data is at the heart of any technology. You cannot use the technology, perfect it, without really understanding through data how it works behind it.
Right, right. So pharma was trying to send videos of themselves to providers and physicians. So why don't we jump on to Susan? What are your thoughts about it, and how did Atrium handle the patient engagement?
So there's, a variety of divisions of medicine and subspecialties within the system. And speaking just on the Musculoskeletal Institute side, many of those orthopedic surgeries, the majority of them are considered elective cases, meaning they're not urgent and emergent to save lives. So the system had to cancel elective cases for a couple of months, which had so many implications for patients waiting for surgery, being in pain, having limited function. That didn't feel elective to those patients. So we had to reach out to those patients and give them ways of managing their pain through that period when it was uncertain when we would be able to reschedule those surgeries. At a healthcare system level, Atrium Health needed to stand up mobile COVID testing clinics. They stood up many data infrastructure registries to use that data to plan for resources and be able to see the spread across our region to plan the resources of getting mobile testing kits and infrastructure out to those areas. They had to stand up the virtual health very quickly. That meant in-hospital and outpatient, which are two very different delivery models. And standing up those virtual health visits, getting the doctors familiar with it, getting the support staff familiar with it, trying to figure out how to merge those data in with our usual EHR data, what was missing, and I will talk about that further, but there were many, many moving parts inside of the healthcare system. And being able to then create some safe environment for patients coming in for urgent, emergent, life-saving treatment, getting spaces set up to be safe, testing, as patients checked in, all while transitioning to a new EHR. It's been hectic.
Yes. Tina, what are your thoughts about it?
Yes, absolutely. I have a lot, but I'll try to condense them. So I have the unique perspective of when COVID first started. I actually was working for Change Healthcare still at that time, and I was leading a technology-enabled services group that was all focused around helping provider organizations and ACOs mash up all the clinical operational data and make insights out of it. So at that point, my customers were reacting at the beginning as elective cases started canceling, and that's the lifeblood of most of your provider organizations. And I'm sure Susan can definitely attest to that with orthopedic. And as both those elective cases started canceling, and this was unprecedented in such a large scale way, and they were trying to understand the impact that was going to have to them operationally and financially, of course. So we also had access at Change Healthcare to a large dental database that actually has 97% of the claims in the country. We took that dental data, and as those dental cases, we found that that was a leading indicator of what was happening with electrical surgery procedures and others in the hospital. So we used that dental data, created some models, and ran a predictive model to look at what we expected would happen to our customers and the provider side and what that impact would be, both from a cost, from a capacity. And then, so that was very helpful to them to be able to start staying ahead of the puck somewhat on understanding this. And this is back over 18 months ago when it first hit. And then we also think about from a provider setting. I mean, these folks have daily dashboard, daily huddles every single day, and all the statistics that were on the dashboards that they had looked at for, the last decade, were irrelevant. So now all of a sudden we needed new indicators on the dashboard. We need on the daily huddle. We needed things like understanding how many patients on vents, how many vents we had available. We needed to understand the overall isolation, how much isolation material and how much protective equipment. And so the daily indicators changed radically, and it also changed against the operating model. Hospitals had refined just-in-time supply chain, refined it, because it really managed cost. And now we're being burned by not having enough ventilator clean kits or enough PPE equipment because the supply chain had radically changed. So that was a huge on the provider side. I'll fast forward to where I find myself now on the payer side. And the things that we'll talk about there is that digital front door. And so COVID quickly exposed those that either had a digital front door already and a digital strategy are doubling down on it, such as Anthem, and that's where we're at, or those who did not, and now they're finding themselves behind the 8 ball and really challenging to catch up to that digital front door, because as Susan said, finding a way to engage those members and patients quickly was important. And especially one of the areas that I feel like we've done a great job at, and I'm really excited to share, is if you look at you look at what's happening in the industry and in the world right now, and we're hearing statistics like you're hearing behavioral health issues are over 100% increase in terms of depression, opioid, alcohol, suicides among youth. So behavioral health has become an urgent crisis in our country. And so we happen to have some, Beacon Health is a large subsidy of Anthem, and they're a behavioral health company, and they already had telehealth presence. And so we're able to very quickly, behavioral health, as it happens, is a very easy thing to convert to digital medicine. So it put us in a position to very quickly be able to respond to that crisis, to be able to do phone consults and crisis lines, and to be able to help intervene in some of those immediate crises out the front door. So again, being digitized is a huge theory that I think you're going to see many more organizations continue to really double and expand their strategy and investment in that space.
Yeah. Thanks, Tina. And as all three of you mentioned, a lot of digital channels, a lot of data that was collected. So in terms of all that digital exhaust which was coming in, and all that burst of data, whether it is from, member engagement or the apps, the virtual care, what were the challenges did you find over there? Because immediately you saw the inburst of all the data and you had to do something about it. So Tina, would you like to talk about it first?
I would, yes, thank you. And so there are a couple things. The first is it really exposed all the gaps in data we didn't have and what we really needed. So from the first place, if you think about from a payer perspective, and those of you that may or may not fully understand in healthcare, claims, the concept of a claim drives everything on the payer side. And so if people weren't showing up to have elective procedures or going to the doctor, they weren't generating a claim. So therefore, our visibility into our member base, those 80 million lives that we serve, our visibility went dark. And so we exposed very quickly that we didn't have the types of information like immunization records or testing results where people were going to have their tests and such. And so we had to really scramble in a unique and different way to try to create new partnerships rapidly to get data in to fill the gaps where we had them. Along that line as well was just looking at things like it really uncovered more, even at such a progressive large organization like Anthem, we still uncovered the gaps we had in ethnicity and social equity and things along that line, which really, again, were big drivers in helping understand our most at-risk population, our most at-risk members in a way that we can engage them proactively and stay ahead of that. So if anything, Shika, I wish it was more of a data exhaust. It was really more for us. It really exposed the vulnerabilities in our data. But I'm excited about that. If you go back to my superpower of a compassionate agitator, I think it's going to help us accelerate people saying, you know, this interoperability and getting that data connected to serve us on a better, more global way. So that was the important thing. And I think the other thing really quickly, just from that payer technical side, was the fact that we talked about the advances and acceleration in telehealth, but the data challenge of that was that there were no codes there. There were very few codes for how a doctor or a physician would actually code that experience. When you go to see a provider, they fill out forms and put a code on that, and that's what generates the claim to pay through the process and starts the whole cycle. And without a code, and there weren't many out there, so we were up into June and July before we really had updated procedure codes and such that were mapped to telehealth. So we had providers that were just in the dark scrambling on how to treat for their patients because they couldn't do that. As a payer on the back end, we're getting a mishmash of stuff that is putting us in a challenge in terms of trying to do payment accuracy because these things weren't coded the way that they have been done traditionally. And so the catch up there and the lag, again, has just created a lot of messiness on the back end. So we find ourselves on the payer side having to do a lot more cleanup, if you will, a lot more integrity checks on those claims that normally would have been much more automated because of this catch up and the lag for those telehealth conversions.
Yeah, thanks, Tina. Susan, you mentioned that a lot of data entry sites were open, right? You were having those patient engagement if you're having any of these symptoms, COVID-related symptoms, and other ways to engage the members.
Right.
How did you manage, again, in terms of intake of all that data and getting information out of it?
Right. So we collected data. You know, if you visited an Atrium Health facility of any kind during this, you would have answered some questions about symptoms and exposure, and that data infrastructure had to be stood up very quickly. Really, all of the data infrastructure and all of the that type of work and all of the resources really went into COVID. It was sort of an all hands on deck across the system. And one of the ways that we decided to collect data and use the data was around resources, making sure that Atrium Health had what it needed for the community in terms of testing, in terms of care, in terms of ICU beds, in terms of ventilators, in terms of all of that to handle any surges that might be coming. So they stood up a research task force that was a very organized committee structure, consisted of an executive committee, 3 subcommittees around reviewing science, a committee around operationalizing it, making sure the appropriate resources were brought to the table to stand studies up and registries up, and then a dissemination subcommittee for the research manuscripts. But the data that was collected in terms of those research registries was really then used for predictive modeling around how to pre-plan for any surges and resources needed in different areas. So there was lots of geomapping work done with that data to really make sure that we had what we needed to get things out into the community.
Thanks, Susan. Megan, coming to you. When we talk about vaccines, right? Typically, a vaccine used to take 4 to 5 years to roll out. But for COVID, it was an urgency. And mRNA vaccine was developed in a matter of weeks. So how was data leveraged and what was going on behind the scenes?
Yeah. So COVID-19 really gave biopharmaceuticals, the biggest challenge, the biggest opportunity, I would say, because not only this was a new pathogen that has not been seen in humans before, so the efficacy wasn't a guarantee. And secondly, the RNA is not, it's a novel technology, hasn't been used before in vaccines. So this were, from a practical viewpoint, quite big challenges for biopharma. However, the data science played a pretty massive role here, because practically it took pharma more than 5 years, sometimes 10 years, to develop a drug from the beginning to getting it to the market. And when we talk about COVID-19 vaccine, it took less than a year. So the speed was like 10 times faster, basically, to do this. And the data helped a great deal in accelerating the process development, designing the experiments in such a way that the data was analyzed in parallel. Normally a pharmaceutical company would run, phase 1, phase 2, phase 3, one after the other. While with vaccines, all these phases were running in parallel, just to make sure that everything was at the high speed possible and was complete de-risk of the process. And another very big element, besides designing the experiments in such a way that they could have a faster read of the data and efficacy of the product, was the manufacturing process, because that's a very complex process in pharma that requires a lot of data mapping, as well as the rollout. We're just talking actually about the rollout of vaccine now in the United States. We all will be vaccinated by, June timeframe. And that's a major achievement. And imagine the kind of data analytics it took to really map out the whole population of the United States, where the biggest needs are, stratification by age group, by, nursing homes, by healthcare professionals. So a data scientist should remain very proud in this process of rollout of the vaccine. And it's just a really big celebration of where the data science has, what has achieved, actually. And I actually did not work for Pfizer during this time of the vaccine. I had left the company, but one thing that I heard that inspired me was that Pfizer leadership had approached the scientists to really motivate them to invent the vaccine first. And the CEO really motto was, as humans, we can achieve a lot more than we believe we can achieve. And I do think this is a good rule of thumb in life, and especially for young women who are starting their careers, to really have faith in themselves that we are capable of really doing a lot more than sometimes we do. And as women, sometimes we doubt ourselves in the workplace, and we really want to have proven everything that we are deserving of things. But I do think that it's we are all very capable of achieving great things in life, and this is a big testimony of what humanity really achieved these times.
Yeah, absolutely. We do need to celebrate all the data scientists and helped us get the vaccine much earlier, and thanks to them, we all will be vaccinated by end of June, and hopefully get to our normal life.
Yes.
Susan, while the vaccine was developed, providers like Atrium had a big task of distributing it. How was the vaccine rollout and the program associated with it?
Sure, but before I answer that, I wanted to just piggyback on that last comment. One of the principal investigators of the vaccine trial at Atrium Health developed a registry and sent out to all of the patients who had visited Atrium Health in the last year, and as well as employees. And it asked questions about interest in and knowledge about COVID-19, asked interest about whether they were having symptoms, they had been exposed. And it was and then ultimately, are you interested in participating in any clinical research around vaccine development? And that was launched before the vaccine arrived to test. So it allowed her to enroll like 464 patients immediately because she had this huge registry to draw on. So I'm actually analyzing some of this data as we speak. I have to have something out this weekend to tie that registry data of interest to participation, and hopefully down the road to some outcomes around it. So that was very interesting and novel work to get enrollment in very quickly. The vaccine rollout was, of course, the foundation of that was data as well. So everybody had to register in North Carolina. Everybody had to register with the North Carolina Health Department and then be approved and put on the list, and stratified by age and comorbidities. Emails then went out about timing to be able to get the vaccine. You can sign up now. So all of that infrastructure around communicating with patients of the whens and the wheres to come get the vaccine was held up by data. So the vaccine rollout through the employees was done through a number of drive-through and mobile drive-through clinics. You drove through and got the vaccine and drove out. After 20 minutes, you parked in a parking space and then drove out. As well as employee health clinics were used. For the community, there was quite a bit of engagement and collaboration with large-scale event arenas across our region. And so much planning had to be done to make sure that those were resourced properly with medical supplies as well as people. So there was quite a bit of redeployment from employees across the system to man these mass events. And originally, when these things started to be rolled out, we had to take paper that had been completed and enter that into an Excel spreadsheet. And after about 2 weeks, after the IT department had an opportunity to quickly stand up a better electronic digital mechanism to do that, it became automatic and entered in at the site. So that was helpful. But I was redeployed to enter data into an Excel spreadsheet for 2 weeks. We did anything we could to, just support this system and support each other.
That is absolutely, definitely the whole humanity actually came together to fight COVID-19.
Right. I mean, the system had people out sick, frontline healthcare workers getting COVID and having to be out. It was people were redeployed all across, and are still some redeployed in the very beginning and haven't gone back to their regular jobs yet. So it's definitely been an all hands in effort.
Absolutely. So we talked about the data and analytics. The next cycle is the data science, right? And typically data science relies on historical data to predict future outcomes. But COVID-19 was a random event in terms of a data science language. Any good forecasting model would need at least 12 months of historical data to make predictions. So Tina, talk to us how COVID-19 changed the existing data science models that you had to play with.
Yeah, no, that's a great question, and to say disruptive is that's putting it mildly, because if you think about on the payment integrity, and so if we talked about before, for just a brief education on how healthcare is paid by and large across our country and our health system today, the claim is the holy grail. And so it's been in existence for decades. There is a very long and complex cycle from when that's kicked off to all the way to the end. And there's a lot of handoffs and a lot of checkpoints in between. And so with each one of those handoffs and checkpoints, there are hundreds of algorithms that are run against that machine learning daily to look for anomalies. And you'll hear us talk a lot about anomaly detection. Those anomalies are built on those models. And so now when claims all of a sudden became less than the gold standard and we have many gaps in our claims, things that we just don't know and have had to scramble for other pieces of data to be able to try to fill that gap, it's broken all of our models. And so now we have our data scientists, which we have hundreds of them. So keep plugging away there. We're always looking for great recruits. Hundreds of data scientists who spend now most of their day trying to run scenario models because we just really don't know what we don't know. So it's a data science playground right now, but we're running multiple models and scenarios. There are daily calls at all the way to the top at Anthem where they're looking at this, well, if scenario A versus scenario B versus scenario C. And then along those are trying to predict how quickly will people return back to safe and having the procedures. When we do return back, will they be sicker, as many people think, because they withheld predictive services? They just went from what we classify as a rising risk category to a full risk category. And so we'll have higher healthcare costs. And so there is a lot of modeling having place now. That's new models, to your point. We don't have the history. It's been terribly disruptive. And so it's put us in a lot of, well, if, then, but, and type of scenarios.
Yeah, and this data is going to be always there, like come 2022, yeah. 2020 data, which is like, as you mentioned, less claims. And I think payers had a great year because not many people went in for their electives. And once everyone is vaccinated, they will go back, and that surge in the surgery departments and in those elective procedures, right? So how do you handle going forward, even for your future data science models? Should you toss away this 2020 year data, or should you do something about it? It's going to be seen how we handle that. And so with all those things that we talked about, the data and the data science, what do you see the future of care, and are we better prepared now for any new crisis that comes our way? Megan, I would like to start with you.
Yes. I would say that COVID-19 has prepared all of us in multiple ways in general for a different future, for a new norm. I would say that when it comes to the future of healthcare, it's all about patient being at the center. Because of the access to information, we are all much better informed about, the new medicines, about our health, and all the wearables that we have today and apps we use really allow all of us to track our health parameters and biomarkers. So the way I see the future of healthcare is where the patient is at the center. We all will be co-decision makers with the doctor, and the technology and the data will enable this at a very, very fast pace. So it's an empowered patient actually that will drive the healthcare system in the world actually. So biopharmaceuticals are fully aware of that, and they are putting the patient at the center, helping the patients actually be more knowledgeable, helping the patients have a meaningful discussion with their healthcare providers. So it's definitely a good time to live in the history of humanity, where we have more power as patients, and the science is evolving at such rapid rate.
Susan?
I think one of the biggest things that we need to do and focus on as healthcare professionals is to bring the data that we use regularly to the community in ways that they can consume it properly and in ways that they can understand it. And we need to engage with the community in ways that we've never done before to build and really repair trust. And many segments of our society that have never trusted medicine and have never trusted science. And without building and repairing that trust, the challenge of dealing with the future COVID long haulers that are going to come into our systems forever, and if this becomes seasonal, really forever, that we're going to need to be engaged with our community and our society in ways that we haven't been before. What does that mean? It means having nice websites where people can go and see data and see what we're doing and why we're doing it. We've got data scientists back in the room crunching numbers and building fabulous models and sending it to policymakers and decision makers. But is it reaching the community so that they can understand and see how we are working for them? We're all doing this. And if we work in healthcare in any way, we're all doing it to make our communities more healthy. Telemedicine is going to be here forever. And so we need to do a better job with the interoperability of that so that it's talking to all of our data systems within systems and across systems, because this really opens up, just like this conference is open up to people all around, healthcare can be opened up. We can have a virtual visit with somebody in Charlotte. I'm in Charlotte and somebody in Seattle because they're the world-renowned expert. And we have to figure things out like imaging. How do we get imaging in when there's been a virtual visit? In orthopedics, you have to have an X-ray almost all the time. So how do we do that? How do we bridge that gap in diagnostic data that's needed? And then figuring out the reimbursement for it. Tina alluded to that in the very beginning. Doctors like virtual care. It allows them to stretch in an inpatient setting. They can be all over the system talking to people virtually. So that allows them to be in multiple places at once. And patients like it, but not every patient has access to it. And that's a problem. So we have to figure out that access issue as well. So there's many things that we can all figure out. It is, for us, it is a playground. There's a lot of opportunity. And so if it allows us to be dynamic and grow and stretch ourselves and not get complacent about what we're doing professionally, because it's also our passion.
Thank you. Tina, what are your thoughts about it?
Oh, I'm highly encouraged. I hate that we had to go through something like this to get there, but I'm highly encouraged at the degree of advances in data that we're making rapidly. As I spoke earlier, my job as I was brought to this organization was to connect data across multiple areas to create new insights. And just over the brief period of time, we've been able to add vaccine data, which, believe it or not, even as a payer, like we are and pay for people's medicine, we didn't have access to vaccine registries before because the states controlled that and it wasn't something that we could share. We now have lab result data and clinical data. We've added more social data and such within there. So I'm really excited about what this has done in terms of data sharing and the need for that. So that's huge for all of us. To Susan's point, I absolutely agree. It's what we can do to engage members, to engage patients, engage consumers. Consumerism is huge, and I think it's done wonders for that business too. On our side perspective, we've really doubled down on our investments in two key areas. One was digitization, which we were already way down that path, and the second was also what we're calling our concierge and health guide services. So with all of our plans, there are health guides and concierges that are meant to wrap around the members to be able to be there to help answer those questions, connect the dots, educate them both on proactive campaigns that are outbound on key topic areas. When things like COVID come up, we're now really equipped to have personalized health guides that reach out to our members, and then also on inbound campaigns with questions that consumers have with that. So I'm encouraged that it's exposed a lot of our flaws that many of us in the system knew were there and have been banging our head against the wall, but it's given the accelerant, if you will, that was unfortunate that we had to endure, but it's given us the accelerant. So I'm really encouraged about the way this will help us really approach whole person care and the care journey, and to be able to really invest in the appropriate places to make it happen.
Yeah, and having patient in the center and to be owner of my own data is important. And this also gave us the window in terms of collaboration. All of us have to work together, whether it is a payer, pharma, provider, to be able to exchange my own data as a patient. That's extremely important. So with that, I would like to open for Q&A. Mia, if there are any questions, do let us know.
Yes, we have one question from Ruben. They're asking, how do you see the new CMS mandate of data sharing requirements will impact better data access and data fluidity between payers and providers?
Oh, I think I'll take a quick stab at that. I mean, it's long overdue, for one. So I'm really excited about it, and it's certainly spurred a lot of activity for my organization in allowing us to have access again to more of those critical data points that before have been highly unstructured or unstandardized. So it's lit a fire under the industry, and so our first milestones are coming up here in a couple months, and so we'll see how quickly the industry can respond to it, and some of the vendors and organizations that will have to work with that data, because it'll be challenged. I mean, if you think about what the EMR wave did to healthcare, it was billions of dollars and decades of effort, pain, and agony to roll out, and so it won't be a quick fix overnight, but I'm encouraged about it.
Thank you, Tina. Mia, are there any other questions?
So far, that's the only one that we have.
All right. One question, let me ask the panelists. A lot of, we always talk about the member engagement, and typically, what have you observed? People who are really engaged on the apps that we have or the different platforms that you all provide as a provider or a payer or as pharma, what kind of personas people are really engaging, right? Is it the folks who are already worried about their health and they are conscious about exercises, or people like me who are just behind the desk and working all day? So what has been your experience? Anyone who wants to take it?
I'll jump in there. Susan may have some response too, because I know they have a large member population or employees, customer, patient, consumer, choose the word, right, at this point in the industry. Because we do have a pretty big health guide service, we track these stats in ad nauseum. And so what we do find, we stratify folks, right? And you've got the healthy well, to your point. It's the people who are like, I want to see the trend of what all my steps are doing with my glucose level and my blood pressure. And so they really want to focus that. And so they typically will call with different types of issues and looking for where they have benefits around health seeking opportunities or how to connect their devices to get more. So we get a lot of questions in that space. Then you see on the other end more the rising risk and the folks that have a lot of interaction with the healthcare system, typically just a lot of help trying to navigate the claims. What does this mean? Do I really owe this much? And so it's really all about just trying to navigate the complexity of the claim cycle, which is why we have a huge business in that, what we call payment accuracy space, just trying to do integrity checks along every point. And I think, Susan said it earlier, right? I mean, we're all committed to that right care, right place, right time, for the right cost. And it's all about appropriateness. And that's one of the other ways I guess I'm encouraged in the industry, right? More data helps us drive more evidence to drive more appropriateness, which is what all of us really want in the healthcare system.
We do have one more question, and this is from Suzanne Long. With the rapid growth of new data collected, what roles in your organization drive the questions that will be asked and answered using that data?
I can tackle this. Every function in an organization needs the data. HR needs the data. Marketing needs the data. Supply management needs the data. Technology, IT organization needs the data. So I would say is data has become the linchpin for all the decision making. So what you do is at the center of any business actually, and is a driver of the decision making. So the roles would be the role of a chief technology officer, the role of chief digital officer, the role of chief marketing officer, the head of supply management, the CEO, the CFO. They all ask questions that can be answered through the data. And this is actually very empowering for you to be in a very, very useful profession, actually, that will drive decision-making more and more in biopharma and in every industry, practically.
Yeah. Susan, you want to add to that?
Sure. I'll speak from Ortho Carolina perspective, because Ortho Carolina is a private physician-owned practice. And so private physician-owned practices aren't necessarily known to have the resources and the infrastructure to collect data to drive evidence-based decisions, either from a business perspective, from a resource perspective, or from a clinical perspective. Ortho Carolina made a decision to invest in data infrastructure 7 years ago. They've been cutting edge. They're in value-based healthcare space. Every decision they make is made based on data. So they have a variety of different software platforms that are collecting data in HR space, in financial space, in clinical space, in utilization space, in clinical outcome space. They've got a data warehouse where all that data goes. And then scientists are able to mine that data and build reports and databases to answer the questions at hand by any number of people across the company. Healthcare doesn't make decisions really anymore without data, either from a healthcare delivery or a healthcare operational perspective. It is all about the data.
Yeah. Yeah, well, this has been a fun discussion. We learned a lot. Switching gears, any parting advice you would give these young women in data science? How has been your journey? A minute each. So we'll start with you, Tina.
Yeah, I'd be glad to. So I'm going to do a really quick walk down memory lane as my advice for you. So I'm so excited about this place in time that you find yourself and the opportunities, because when I went to college years ago as a math major, because I loved math, I loved the numbers even then. About halfway through my first semester, my advisor said, "What do you want to do with math?" And I didn't have an idea. Data science wasn't a thing then. I said, "I don't know. I just like math. I'm good at it." They said, "You want to teach?" No, I couldn't see myself at 19 teaching. And so she said, "Well, guess what? We have a great nursing program. They use a lot of math in nursing. Why don't you switch there?" So I said, okay. Of course, nursing does not use math a lot, but ultimately I wove myself through, right? The universe has given me a great path because I was willing to say yes and keep pursuing my passion, which was math. Went on to be in a hospital side, got my MBA, got my black belt, got into the industry, continued to push on data and get to the point I am today. So my encouragement to you is like, what a great opportunity that people aren't going to just try to say, oh, be a nurse, right? Now we know what we can do with data. There's so many opportunities. So just keep pushing your curiosity, be curious, and be a storyteller. I look at the types of roles that we hire and what we're looking for, people who are curious and people who can tell a story with the data. It's not enough just to be a magician with the data anymore. Tell a story with it. What's the narrative? What's the so what? That's my advice for you. Yeah. And good luck on your journey.
And Shika, building on what Tina said, my advice really is that you are in the best possible profession or space you could be in today's time and age, basically, because it's what you will bring to the table will be critical to decision making to any corporation. My advice would be to really understand the context of utilization of your data and understand the business. So if you decide to enter in a space that goes beyond like pure research, understand the business, because the storytelling is all about really what this is doing for a business. And so don't just stay in the technical side of things, but enlarge your space to really be a decision maker with your data through your story, through understanding of what matters. Why am I doing this? What questions I am answering? So it's very important to wear a business hat as well as you work as data scientists. So my recommendation is take business classes, have a minor in business along with data science, and really believe in yourself. And as Tina said, be curious and be brave as well. You are better than you think you are, actually, most of the time as women.
Thank you, Megan. Susan?
Yes, I'll echo on what Tina and Megan have said. The ability to have conversations with people that don't understand data, but need the answer to a question that the data is going to answer, and you are going to be the magician to give them the answer. If you can't have those conversations and you can't listen to what, when they say something, what variable is that? When they ask a question, be visualizing that data and your analyses and your plan in your head while you're having the conversations so that you can ask questions very quickly. It's that storytelling and those conversations and being able to deliver that information to them so that they can consume it. So not using jargon and learning what the language is at different levels of the company, as everybody's mentioned, it is absolutely invaluable.
Thank you all. This has been great. Thank you for giving us time and being part of Women in Data Science for Charlotte. I learned a lot from this discussion, and I'm sure our audience did. And one advice I would give these young women is not to be shy. Ask for more and don't give up, because we are really good, but being a woman, sometimes we are really tough on ourselves. So keep up the good work, be in data science. And I want to thank Megan, Susan, and Tina for your time being part of this panel. Thank you, everyone.
Thank you.
My pleasure.
Thanks so much. Have a great day, everybody.
Coming into the data science program at UNC Charlotte, for anybody who's considering data science, I think it's important to consider and to realize that you don't need to be a mathematical genius. You don't need to be an expert programmer. The program will ensure that you have all the skills necessary in order to tackle the future data science problems. I've started from the ground up to ensure that my skills are being honed and being developed as we progress through. And I never felt like I was being left behind, especially with math, statistics, or computing.
Data is the present. Data is already being collected. It's how are we going to use it? Will we use it well?
Data science is more used to analyze outputs of future programs or future softwares, wanting them to go a certain way, and wanting things to go faster, wanting things to improve, and how you can mend programs in order to do so.
History of data science education has mostly been at the graduate level, but employers don't just need graduate level educated individuals to work on these problems. They need individuals coming into the job market with these skills at this level.
I'm very fortunate to be in the only bachelor's program of data science in the state, and beyond fortunate to be in one of the very few, less than 10 in the country. The special thing about a program like this that sets it apart from a lot of other different program and course programs is that the class structure in the course program encompasses all different facets of mathematics, statistics, and computing. So instead of having to take it upon yourself to learn all these individually, the program offers it for you.
Throughout the last 10 to 15 years, data science has always been in the top 3, often the top 1 field where industry needs more individuals with those skills.
They are in line with a bunch of different programs, especially in this part of the country. And my personal feelings about securing a job, I have no apprehension, and I know that there will be more endless opportunities to come in the future.